adult centers. And thank you so much for being with us today, Dr. Pahl. We're so glad to have you. Let me change the screen over to you. Okay, perfect. We can see it.
Okay, do you have my screen?
Yes, we can see it perfectly. Thanks.
Great. All right, it's not letting me advance to the next slide though.
Oh, okay. Um,
Let's see.
Sometimes the arrow also lets you, like on your keyboard, it might let you advance that way.
There we go. So the objectives for this talk are for the audience to be aware of the incidence of heart failure in children and to be able to name the primary types of cardiomyopathies that occur in children, as well as to be familiar with some of the more common heart failure therapies that we use, and also to be aware of a typical presentation of a patient who presented with heart failure and cardiomyopathy. So we'll start with a boy who presented with heart failure. This boy had previously been healthy and was a very active baseball player. He came in with 1 week of being tired and had a dry cough, as well as loss of appetite and a vague stomach ache. He was seen 2 days earlier by his doctor, who diagnosed him with a viral illness. He then came to the emergency room and had chest pain, was dizzy, and had shortness of breath. There was no one else in the family who had any history of any heart problems. So please keep him in mind as we go through the rest of the presentation, and we'll talk about him some more at the end. In the United States, heart failure-related hospitalizations occur between 11,000 to 14,000 children annually, and the overall mortality is up to 7%, with the majority of these being in patients with congenital heart disease. Those children represent almost 70% of children with heart failure hospitalizations. However, cardiomyopathy occurs in about 13% of patients with heart failure hospitalizations, and a small percentage of these may have myocarditis, which is a viral inflammation of the heart. And some children with myocarditis can end up with a persistent problem that can lead to cardiomyopathy. A smaller percentage, about 15%, can have a primary rhythm problem of the heart that can lead to heart failure and may also result in a final presentation of cardiomyopathy. And this was reported by Dr. Rossano in the Journal of Cardiac Failure in 2012. According to the Pediatric Cardiomyopathy Registry, which is a large organization that has published for over 20 years on cardiomyopathy in children, the incidence of new cases of cardiomyopathy is about 1 per 100,000 children. And the majority have a heart failure mortality rate of about 13% at 2 years in the past, but this has gotten much better in recent years with better management. Children in the Pediatric Cardiomyopathy Registry may have a recognizable syndrome in about 1/4, especially those that present in infancy. And about 1 out of 20 have a history of myocarditis, or the viral inflammation of the heart that I mentioned. This is a slide with several different cartoons, and on the right-hand panel, we see that a child with cardiomyopathy may present with various symptoms, which can include respiratory symptoms such as coughing or shortness of breath, and fluid may build up in the lungs, and there may also be swelling of the abdomen from fluid buildup and swelling in the ankles and legs, but this is not as common as is seen in adults. Heart failure leads to the whole body being affected with activation of some different hormones, and these are targets for medical therapy. And we see heart failure leading to activation of hormones within the brain, as well as the adrenal glands and the kidneys. And again, these are all different targets that we use when we introduce medications to treat heart failure. Heart failure symptoms are quite variable depending on the age of the patient, and as I mentioned, can lead to swelling in different areas of the body and difficulty breathing. The older patients may complain of rapid heartbeats or irregular heartbeats, and there may be weight gain from fluid, or there can be weight loss, especially in young children who cannot maintain good weight. There can be abdominal pain, and a very serious finding could be passing out. And sudden cardiac arrest. This is a very detailed slide showing some of the causes of heart failure in children, with the top of the slide showing patients who have congenital cardiac malformations, and the bottom of the slide focusing on the primary cardiomyopathies, which we will discuss in more detail on the next slides. Cardiomyopathy is a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of other diseases. The most common type of cardiomyopathy is dilated cardiomyopathy. And on the right side, we see an example of a cardiomyopathy specimen where the heart is very enlarged, in particular the left ventricle. And this represents about 70% of pediatric cardiomyopathies, or 1 out of 100,000 children who come in with cardiomyopathy. Under the microscope, we also see many abnormalities, which include enlarged cells and scarring of the heart. There are many causes of dilated cardiomyopathy, but in the majority of cases, we do not find a specific cause, and we call this idiopathic cardiomyopathy. Some of the cases can be hereditary. There may be inflammation of the heart from myocarditis. We can see cardiomyopathy from cancer therapies, such as the anthracyclines, and we can also have endocrine or hormone abnormalities, such as thyroid problems that lead to cardiomyopathy. The initial evaluation of a child with new onset heart failure is listed on this slide. It's important to get a careful genetic evaluation of the family for any other patients who may have had heart disease or died suddenly, as is shown in the cartoon of the patients with cardiomyopathy, where all of the patients in black represent patients who had cardiomyopathy. An EKG, echo, and chest x-ray should be performed, as well as blood pressure in arms and legs, and blood testing with complete blood count, chemistries, urinalysis, thyroid studies, and sometimes a cardiac catheterization may be indicated. Genetic evaluation is often important, particularly in the patients who are affected, to see if there is a genetic cause of the cardiomyopathy. This slide shows some of the targets for medical therapy in patients who have cardiomyopathy. Most of what we have learned in treating children with cardiomyopathy comes from routine adult therapy, where there are published guidelines and much more information, since there are thousands and thousands of adults who have been treated for heart failure over the years, and many studies have been published on what are the best therapies. Digoxin is an important drug that has been around for over 250 years and is a mainstay of therapy for outpatients with cardiomyopathy. IV heart medications are used for the sickest of patients, and beta blockers have been introduced in adults but are not as widely used in children. Some of the other targets include ACE inhibitors such as enalapril. Angiotensin receptor blockers are not as commonly used in children, and aldosterone antagonists such as spironolactone are commonly used. Diuretics are the mainstay for children with fluid retention, particularly children who have difficulty with breathing and shortness of breath. And vasodilators and alpha blockade agents and nisiratide are much less frequently used in the pediatric population and are more experimental. Now we'll move to a different type of cardiomyopathy, hypertrophic cardiomyopathy. And we can see from the panel on the left that this is a very different type of problem where the heart is thickened and the ventricle has a very small cavity. This is the most common cause of sudden death in athletes and occurs in 1 out of 500 adults, so it's actually a very common disorder. In children, it is not as frequently diagnosed, as most children who have this condition do not have symptoms. The adult criteria for diagnosis are a septum that measures about 15 millimeters, which is slightly greater than ½ an inch. And in children, we have different criteria by echo to make this diagnosis. Patients with this condition have abnormal heart relaxation, and there may be obstruction to flow out the aorta. Again, as I mentioned, many patients may have this condition and not have symptoms. Other findings can include an abnormal EKG, as is seen on this slide above, with very high voltage in the left ventricle and abnormal T-wave changes. And these patients have abnormalities in the troponin and myosin of their myocardial cells. And under the microscope, the heart cells look very abnormal, and there may be a lot of fibrosis. All of the white that we see throughout on this slide is very abnormal and not characteristic of what we should be seeing when we look at heart tissue under a microscope. Symptoms for patients with hypertrophic cardiomyopathy vary widely. Many patients have no symptoms at all. Other patients may have chest pain, in particular when they exercise, or shortness of breath, and passing out from left ventricular obstruction or from rhythm problems may occur, and this is a very ominous, concerning finding. And sometimes the first symptom could be sudden cardiac death, and if the patient is able to be resuscitated, that patient requires a defibrillator. And what we see in this panel here are the causes of sudden cardiac death, and we see that hypertrophic cardiomyopathy is the most common cause, with about 1/3 of cases of sudden cardiac death in athletes being due to this condition. The risk of sudden cardiac death in hypertrophic cardiomyopathy is about 1 to 2% per year, and is usually due to an abnormal heart rhythm. However, this is very rare in children that are less than 10 years of age. The patients who are at increased risk are those who had a prior cardiac arrest or a fainting episode with exercise, and the patients who have the most abnormal heart are those with a wall thickness that is greater than 3 centimeters or a little more than an inch in thickness, patients who have an abnormal stress test, or rhythm problems when we do 24-hour heart rate monitoring. Also, patients who have an abnormal family history with a family history of sudden cardiac death. And this is still a new field for genetic markers, but we may find that there are some patients who are at higher risk based on their genetic testing. The most appropriate treatment for prevention of sudden death in this group of patients is the use of intracardiac defibrillators and addition of certain antiarrhythmic drugs. Another type of cardiomyopathy, which is quite rare, is restrictive cardiomyopathy. And we do not see too many cases of this in children. This type of cardiomyopathy is seen with amyloidosis, which is a condition that is more common in adults. And when we see restrictive cardiomyopathy in children, we usually do not find a cause. It represents less than 5% of total pediatric cardiomyopathies. However, it may be hereditary, thus it is important to get genetic screening of the child, and if the genetic test is positive, then the family should also be screened. Restrictive cardiomyopathy is shown on this echo image, where we see a typical mouse ears pattern where the upper chambers of the heart, the right atrium and the left atrium, are much bigger than the lower chambers, which is a very abnormal pattern. And these patients also have an abnormal EKG. The evaluation of a patient should include an EKG, chest X-ray, echo, gene testing, and a cardiac catheterization to assess the pulmonary resistance. And if the pulmonary pressures are elevated, generally the only therapy that is definitive for such a child would be heart transplantation. These patients also have a very abnormal EKG finding that is characteristic for patients with restrictive cardiomyopathy. Left ventricular noncompaction is another type of cardiomyopathy that has characteristic features in the left ventricular muscle, where we see these deep recesses here that previously was also called the spongy myocardium, where we see this abnormal appearing trabeculation, where it looks like the muscle almost separates away from the left ventricular wall. And the prognosis for these patients varies widely. There are some patients who can be adults with no symptoms at all, and this could be an incidental finding on an echocardiogram that was performed for screening, or there are some patients who are very ill and present in infancy because of poor ventricular function and may require heart transplantation for survival. This type of feature of these abnormal trabeculations can be present in as many as 5% of cardiomyopathies. And the evaluation for these patients is similar to what we would do for a patient with a dilated cardiomyopathy. The treatment really depends on what else is going on besides the abnormal appearance of the muscle, and what is the ventricular function, and does the patient have any symptoms. Now we'll talk a little bit about myocarditis, which is a fairly common disorder, and many patients could have myocarditis with such mild symptoms that it may not even come to medical attention. Myocarditis is usually a viral infection of the heart, and it can lead to cardiomyopathy, although the majority of patients make a full recovery. In the past, endomyocardial biopsy was considered the gold standard and the best way to make this diagnosis. However, it would require that a catheter, such as this biotome, would have to be placed through a vein, either in the neck or from the leg, and put into the heart, where a small piece of right ventricular heart muscle would be removed and put under a microscope to make the diagnosis. And generally, we would require 4 pieces to make this diagnosis. In the last decade, we're doing fewer and fewer biopsies, and generally we can make this diagnosis based on what is going on with the patient. We're also doing more cardiac MRIs, which have typical findings that go along with myocarditis, as we see these white areas in the region of the heart muscle here, which light up in patients who have myocarditis. And this can be done at the time of the presentation with illness, and then a follow-up study could be done 6 months later. Here's the slide which shows the typical inflammation that we see on a biopsy in a patient who had myocarditis. And all of these purple cells are highly abnormal. These all represent white blood cells, lymphocytes, that are present at the time of a case of severe myocarditis. In general, patients with myocarditis are treated with supportive therapy and bed rest. The benefits from immunotherapy are uncertain. In the past, clinicians have used steroids to treat patients, and intravenous gamma globulin has now been used for over 20 years, but it is uncertain whether there is true benefit. In the most severe cases, we have supported patients with mechanical support, such as extracorporeal membrane oxygenation, as well as ventricular assist devices, and rarely heart transplantation can be life-saving for the patient who does not recover with time and rest. More recently, many cardiologists have begun doing genetic testing on children with myocarditis, especially those that don't make a full recovery, as an underlying gene mutation for cardiomyopathy may also be present in this group. So what happened with our patient? This 9-year-old was diagnosed with myocarditis due to adenovirus, which is one of the more common causes of myocarditis in the current era. He did have some mild initial improvement and was initially discharged, but then had to come back to the hospital as he was having trouble walking even 1 block without having some symptoms of chest pain and shortness of breath. His left ventricle was still enlarged and showed poor contractility, that is, it did not squeeze well. He was rehospitalized and begun on intravenous cardiac medications, as well as IV diuretics to remove fluid from the lungs. He remained stable and was listed for heart transplantation. He was found to be gene positive for cardiomyopathy, and his other family members were tested, and none of them had a gene mutation. 4 months after listing, he received a heart transplantation and was discharged after several weeks in the hospital. He is now doing well and playing baseball again. In the future, we hope that there will be better identification of underlying genetic causes of cardiomyopathy with genetic predictors to allow screening of family members and potential for intervention and prophylaxis so that there can be personalized medicine for patients with specific genetic types of cardiomyopathy to allow prevention of disease before it occurs. We also are using more and more biomarkers such as BNP to tailorize and individualize therapy as we begin treatment of patients. And there will be more novel therapies rather than the current medications that we are using in 2016 to treat patients. Some new potential therapies that are on the horizon and are already in research protocols are stem cell therapy, which is being used in patients who have had coronary infarcts to repair the ventricular myocardium. And some programs have also instituted this as research therapy for treating patients with cardiomyopathy, including children in Europe. Gene therapy using a virus vector may help with normal remodeling and calcium cycling in certain types of cardiomyopathies. Surgical therapies, such as interventions that include ventricular assist devices, may be more beneficial in treating patients waiting for heart transplant, as we have smaller devices that will allow patients to leave the hospital and have better quality of life. And these devices may either be more permanent or patients may recover from their cardiomyopathy and not require transplant. Here's an example of a Berlin heart ventricular assist device, which comes in various sizes depending on the size of the patient, and this is standard therapy for children who are awaiting transplant. And there are various small adult ventricular assist devices that are on the horizon, with these that are shown in the picture approximately the size of a golf ball, and these are now in clinical trials. In conclusion, heart failure is an uncommon condition in children that can result from numerous causes, with cardiomyopathy being the most common. Treatment is challenging because of the variability in the causes of cardiomyopathy and the lack of extensive guidelines for children. We generally are using treatment for children that we extrapolate from adult guidelines without knowing what is the best dosage and the best drugs to use for the pediatric population. Genetics also plays a role, and hopefully we will be able to tailor therapy better to use personalized medicine and pharmacogenomics in the future. Thank you for your attention.
Thank you so much, Dr. Pahl. That was very informative, and we're really appreciative of you sharing your expertise with us today. We're going to take some questions now. So we do have a few questions already submitted, but if you have anything that you want to ask Dr. Pahl, now would be the time to go to your question box and just type in your question, and we'll go through as many as we can get through. So to start, the first question is, my son, age 11, had a septal myectomy in May, and he is taking Norpace 3 times a day and has an ICD as well. He is only 11, and I feel like we don't have any other options left, and he has a long life ahead of him. What can we expect for his future? Somewhat normal, or would a transplant likely be in his future? I know there is no way to know for sure, and probably no normal expectations, but what have you seen in your experience that we might expect?
I think it's really hard for me to answer for your son without having seen his echo or examined him or worked with him myself. It is unusual to have an ICD and a septal myectomy in someone so young, but I always try to optimize my patients' quality of life and encourage them to do as much as they can. It's pretty rare to require transplant for hypertrophic cardiomyopathy. At our own institution, we've only had one patient that has gone to transplant with hypertrophic cardiomyopathy. So I would hope that it's not in his near future, but that's all I can comment on. I think I would encourage you to talk to his cardiologist and ask what they think about that question. It's a very important question.
Okay, thank you. Another question is, as I understand it, diagnosis is based in part on whether the child's heart size is more than 2 standard deviations above the mean. That suggests that anyone in the upper 2% would be diagnosed with cardiomyopathy, but I gather that far less than 2% of the population has cardiomyopathy. If so, what other tools are used to diagnose the child? And this question is with respect to asymptomatic children whose heart function is normal.
I think that's a great question. So we start with EKG and echo, and many times patients are getting an echo because a child comes in with a murmur. A lot of healthy children have innocent heart murmurs, or a child may have some chest pain, and most of the children we see with chest pain don't have any heart problems at all. The chest pain could be a lot of different things, like some muscle pain from exercising. So when I get an echo, if the only thing I see is that the heart size is at the upper limit of normal for the left ventricle and the function is absolutely normal, the EKG is normal, there's no symptoms, everything else is good, I would not necessarily label that child as having cardiomyopathy. I may decide to see them back. In contrast, if I have another child where there's concern about cardiomyopathy in the family, I'm seeing them for the first time, and then the echo looks suspicious, the left ventricle is greater than 2 standard deviations above normal. And often those are teenagers, they want to play competitive sports. We have more testing we can do. That's a patient that I might opt to do a cardiac MRI, which I think might be a more specific, precise test because we get multiple views of the heart and the left ventricle, and we can get function, we can get size, we can also see if there's any abnormalities to suggest any scarring. In short, I think it's a better test than an echo. because it's more precise, but it does involve sedation if it's a small child. So we generally wouldn't routinely do an MRI if we had a young child, but if we had an older child and it was a real question of whether or not the child has cardiomyopathy, we could go to that degree. And then we can do the genetic testing for more specific testing. So simply having a 2 standard deviation left ventricular Z-score doesn't necessarily mean you have cardiomyopathy.
Okay, thank you so much. Another question is, have the advancements in genetic testing helped children be diagnosed earlier before being symptomatic and therefore increase longevity?
So the first part of the answer I would say is yes. I think there are children who are being diagnosed earlier because of screening. We may be screening siblings who may have a positive gene but don't have any evidence of disease, and so they can be followed closely. And then you have the opportunity to intervene early on, either with medication or with counseling, potentially with sports restrictions if it's a child with hypertrophic cardiomyopathy. I think we're still much too early to say what the impact can be on longevity, because this important change in practice in doing genetic screening has probably just been in the last decade.
Okay, thank you. And just to follow up with that question, can you comment a little bit on how a family might initiate the process of genetic testing if they haven't had any background or experience with that?
So I think the most important patient to test is the one who actually has cardiomyopathy. Um, so you start with the person who has cardiomyopathy, whether it's a parent, a grandparent, an uncle, or the child, and do gene testing on that patient. And it's always best to do it with a genetics counselor involved or a cardiologist who has experience with cardiomyopathy. And then if a gene mutation is identified, then they can help do screening on the additional patients. The difficulty that I see with the genetic testing we do is that there are so many abnormalities that show up that are mild variants, and so it can get very confusing. So you really want to make sure that the test is getting interpreted by somebody who can counsel the family when those results come back.
Great, thank you. I don't see any other questions here, so I'm going to thank you once again so much for taking your time this afternoon to share your expertise and this information with us. We're really appreciative of your assistance and sharing with us. So thank you again.
You're welcome. My pleasure.
And for anyone that is on the call, if you didn't already know, I just wanted to remind you that September is Children's Cardiomyopathy Awareness Month. So we have been doing lots of different educational initiatives and awareness initiatives to reach more people and let people know about cardiomyopathy in children. And this webinar was a great resource for us to do that. We're still in the month of September, and we have posted our daily activities on our website, which is childrenscardiomyopathy.org. And you can also follow us on Facebook and Twitter to see what we're doing every day to raise more awareness among the public and to get more awareness out there. So I just encourage you all to do that. And thank you again for taking your time to spend some time with us this afternoon. And thanks again to Dr. Pahl. And everyone have a great afternoon. Take care.
Thank you.
Thanks. Bye-bye.
Bye-bye.